Having me. My name is Shana Makuchi. I am the opioid overdose prevention program coordinator, as well as the maternal and child health substance misuse priority lead at the Colorado Department of Public Health and Environment. For folks that are in the room, there are some handouts up here at the front if you'd like to take one of each. And for those that are joining remotely, all of the handouts and PowerPoint slides should be available online. And so we're going to jump in and get started. If anyone does have questions throughout, please add those into the chat box and I will be sure to address them, hopefully as we go along, but also we'll have some time at the end. So I'll just start by saying that I sit in the Violence and Injury Prevention Mental Health Promotion branch at the Department of Public Health and Environment. This is one branch that falls within the Prevention Services Division. And within that division, we also have other MCH priorities. I'm a little bit unique in that I sit in a separate branch than the majority of the maternal child health priorities that we have. There are various funding sources to really do this work specifically for the substance misuse priority. It's really about how we leverage the funding. And so for our opioid work, we are generally funded primarily by the CDC, which is the Center for Disease Control and Prevention, as well as Bureau of Justice Assistance. We also, our branch receives some funding from the Maternal and Child Health funding through HRSA, although that doesn't particularly go for this priority. And then marijuana uses some of their funding to work on this issue as well. So for substance misuse priority broadly, that's really focused a lot right now on opioid work, marijuana related efforts, and then we also have a tobacco team that I won't really go into that portion of this work today. Like I mentioned, because we are really focused on sort of leveraging funding to be able to work on these issues and this population, you'll be hearing a lot today about different activities in Colorado to prevent substance misuse, statewide opioid overdose prevention efforts, marijuana prevention and education programming across the state, and generally the impact on our state's maternal and child health population related to substance misuse. So today we're really going to start by talking about the marijuana campaign efforts that are actively going on in Colorado right now. It is a relatively new campaign happening, and sort of what the process has been to put this campaign together is we started by gathering data. This does not sit in my particular data work, but with someone else in my branch who I collaborate with regularly. And so really the first step was to look at PRAM's data to tell us why this was an important population to do a campaign around marijuana. And this specific slide is showing population of women that have had a live birth. And so there's a good amount of data there to look at. And this is really marijuana use before pregnancy, during pregnancy, and postpartum while breastfeeding. We also looked at BRFSS data to inform why this would be an important population to do campaigns for. This is looking at a health disparity in use. This is daily or nearly daily marijuana use. And this is, you can see, separated by male and female. And this is looking at women of reproductive age broadly. So this is ages 15 to 35. Oh, sorry, BRFSS, I'm gonna have to think of spelling out what that is. It's one of our data sources that we were asked in the room what this is really showing, and this is about showing prevalence in the difference between male and female for daily and nearly daily use of marijuana. So for women of reproductive age, it's showing that for females 15 to 35, that's kind of what those numbers show. And you can see the prevalence percentage at the bottom. So this campaign really had an objective to drive women to a website that connects them to information and resources to make the most responsible decision for themselves and their baby around marijuana use while pregnant and breastfeeding. The audience really has two audience focuses, I guess, for this campaign. Pregnant and breastfeeding women in Colorado, sort of the primary range is that 15 to 24 of low social economic status, and then the secondary is 25 to 35, also low economic status. This is actually just one arm of the marijuana campaign. There is another arm that is broadly for marijuana consumers. The messaging in that campaign could still be very important for the maternal and child health population or women of reproductive age because of the rates of unintended pregnancies, as well as for overall health and shifting screening practices. So some of the materials that go out are for providers, some are more focused for women themselves. This is one of the materials for, can you see it in the camera? Okay, so this is one of the materials that gets hung up in clinics, like WIC clinics, doctor offices, etc. And it's what do you want to pass on? Your smile, your sense of humor, THC from marijuana. And it has a mom and a baby. And the little message down here is that there's no known safe amount of marijuana to use while pregnant or breastfeeding. Learn how THC from retail marijuana could be passed to your baby. So really the big messages are in yellow for moms to get thinking about this. And so this is just one of the materials, and I'll get to showing where you can access the materials that we're looking at today. This is really the overall direction for the campaign, is the what will you pass on. So mothers and moms to be spend a lot of time thinking about things they want to pass on to their babies. And the campaign is intending to use powerful imagery to spark emotion and get mothers thinking about what they would want to pass on and what they would not.
Yeah.
Because there's no known safe amount, we are really sending messages that we want to prevent use because we can't guarantee, you know, how much is really safe. These are some of the sort of digital ways that moms and women of reproductive age are reached. Digital ways is one of the two top trusted ways that women of reproductive age and pregnant women access information. And so posting things through Facebook, mom blogs, etc. online is like the top way to reach these folks. And then doctor offices are another trusted space. And so we also have materials for doctors. Some of them include, and I can pass these around in the room, these are also available online, and I'll show you where to get those in one of my upcoming slides. Pediatric exposure prevention. This is clinical guidance for Colorado healthcare providers, as well as one that's marijuana pediatric exposure prevention. These are clinical guidance tools that providers can look at prior to working with any patients who come in that may be pregnant or maybe a woman of reproductive age and using marijuana. One thing to note, though, is that the messages are promoted primarily through digital ways because this population is less likely to receive prenatal care. And so having a space where we can still reach moms or moms to be pregnant and postpartum folks digitally seems to be the best way. And so what we did, sort of started to talk about this, was we gathered some data. Then we did some focus groups and an online survey and really wanted to talk to the population. What are the attitudes, the behaviors, the perceptions around marijuana use, etc. And then we worked with what's the word that I want? Sorry, partners that that really built this campaign. And then once we had things put together, we really did a test with those same folks that participated in the focus groups. We wanted to test that the content, the messages, the tone, the pictures, that all of that felt like it was useful in getting the right message across. So basically the question was, are we messaging to the right people in a way that they can hear? And then essentially get feedback and implement that. So a couple things to note is that part of the focus groups or folks that were surveyed, 72% were current or previous marijuana users. And based on the test run, 65% were motivated to not use marijuana after seeing the ads. So that's a pretty good amount. And women felt that the visuals were attention grabbing and connected, and calling out THC as being harmful was helpful to women to understand why marijuana could be harmful if they're pregnant and breastfeeding. These are some of the available resources. So like I showed you, the poster for the provider offices, I passed around some of these guidances for providers. And then we also have this little fold out palm card. This is actually meant to be used in a clinical setting, but really step by step, so a doctor can go through each section with the patient and talk about how there's no known safe amount, that pumping and dumping isn't the solution, etc. These resources are all available online. You can go to the marijuana site on our Colorado Department of Public Health and Environment website, and you should be able to access these materials there. There's also a space online, I want to say it's cohealthresources.org. If you are a public health entity, you likely have a login to get on there and order materials. If someone is looking to get materials and is having a hard time finding that, please feel free to reach out to me and I will connect you. I'm going to pass this one around in person for folks in the room to see. And then, like I mentioned before, we also have the broader campaign, Responsibility Grows Here. We also have a palm card for that one. And like I said, this could actually still be useful campaigning-wise for folks because of the rates of unintended pregnancies, and also because these materials that we developed are really to get broadly at reaching providers. And so this is just another one that you can access online, but this goes to the broader campaign. It's not necessarily specific to the MCH population. So we're going to take a second. I just want to see if anyone has any questions about some of the marijuana pieces that we just talked about, since that's the primary project that we're doing for the maternal and child health population, pregnant and postpartum women, women of reproductive age. Any questions?
Hi, you mentioned that there's no safe amount that has been identified of THC. Have you identified an unsafe amount? And if yes, what does it look like? Do you have, birth defects, research like that?
So great question. If anyone didn't hear that, it was a question about, is there a known unsafe amount? To be honest, there's a lot of research that still needs to be done. So all we can say for certain is that there is no known safe amount. We do not collect at this time any kind of birth defects information regarding marijuana that I'm aware of. Anyone in the chat box? Okay. So we're gonna next go into the opioid overdose prevention unit. This is really where I sit. This is what my unit looks like. We have our branch and our branch chief who is heavily involved in our opioid overdose prevention activities and work. We have a lead injury epidemiologist on our team, an evaluation supervisor, of course our unit supervisor, myself who is the coordinator and MCH lead, an epidemiologist who helps run all of our data, and then we have 2 evaluators on our projects. We have a number of activities to work on this issue. Data surveillance, Pdmp enhancements. Pdmp is the Prescription Drug Monitoring Program, and I will go into a little bit more about that shortly. We also work on provider education efforts and coalition building or community strategies. It looks like the chat box is blinking. Oh, okay, perfect. Okay, so first we're going to talk about some data, and I'm going to jump over to another page, just make sure that comes up. Are folks seeing data, a data dashboard? Okay, perfect. So this is from our state action plan for our maternal and child health priority. This is what our goals were and our strategies between October 2017 and September 2019. And what you can see here is that one of our goals was to decrease the percentage of women ages 15 to 44 in Colorado who use non-medical use of prescription drugs during the past 30 days, from a 15.3% to a 14.5% by 2020. And you can kind of see that we're really like on target with that. Hasn't moved a ton. We're still working on the strategy of expanding data collection and surveillance to understand the scope of prescription drug misuse outcomes for pregnant and postpartum women. And so we will continue to work on this throughout to try to meet our goal by September 2019. We also have a strategy to increase access to disposal sites for prescription drugs to limit availability, promoting the use of our prescription drug monitoring program, doing some provider education with healthcare providers on safe prescribing practices, and the known effects and risks from prescription drug misuse. We're also working to decrease the percentage of women ages 15 to 44 in Colorado who use marijuana during the past 30 days by 15.3 to 14.5%. And this is highly focused on provider education efforts, as well as working with partners to inform and disseminate mass reach health education campaigns. So like this marijuana one that we just discussed, that is really a way to meet that sort of second strategy. The first one, we partner with folks like the Colorado Consortium for Prescription Drug Abuse Prevention, which I'll talk about them a little bit more later, as well as the Substance Exposed Newborn Committee and their work groups. Okay, I also just wanted to show another map about any drug overdose, county of residence. You can see some numbers here, breaking out female and male. And this is really looking at overdose deaths among Colorado residents. You can see the age groups. So really that 15 to 44, there are some high rates there. And you can use this map, it's interactive, to put in a specific type of drug overdose if you wanted to do any opioid overdose, prescription or illicit. You could also put in a specific county or health statistics region to break this out a little bit more. You can, impact what years show up on this chart to really get a better idea of what this looks like in your community. It also breaks out some information by race and ethnicity, marital status, etc. And of course, there's always a suggestion box. So if there's an issue when you're trying to look for information for your county or your health statistics region, you can always drop a little comment in there. Another data sort of map that we use is really looking at age and other social determinants of health, like poverty, unemployment rate, things of that nature, to understand drug overdose deaths in the United States. We can specifically go to Colorado, and we can pull up just some details about Colorado specifically. You can also pull up specific counties within Colorado, and you can impact the different race, age, disability status markers to decide what information you'd really like to collect and look at more intentionally. So the note that is important here is that socio-demographic and economic data are provided to show composition of the total population, so they do not reflect the proportions of individuals who died as a result of overdose. Let me just see. Oh. Whoa, I'm gonna take this screen down for a second. Okay. The next thing I want to show is something that I brought in the room for folks that are here, but you can access this online. On our colorado.gov /CDPHE/opioid overdose prevention, I think, is where you can access our prescription drug data profiles. I printed out some in color here. They're lengthy. There's a Colorado opioid data profile, which is what I have in the room here. This just shows some of the different types of national trends, sort of where Colorado fits in with that scene. You know, so you have opioid-related drug overdose deaths, you have drug overdose death rates, and then you can kind of see down here, we have more information about prescription opioid death specific statistics. We also have an opioid-related age-adjusted overdose death rate map. We also look at things by health statistics regions. There's a ton of information in here. And you can also go, I'm just gonna go back really quick. You can go to each county specifically. So if you work in a health statistics region or a specific county, you can click Conejos County and pull up their information and just their individual data profiles for each county to give you a little bit more to maybe inform the work that you're gonna be doing in your community. So I'm going to jump back to my PowerPoint. Okay, and we're gonna keep going. If folks have questions about data, I'm happy to connect you with our epidemiologist, because it's definitely not my primary forte, and I will try my best to answer them if folks have questions right now in the room. But I'm gonna talk a little bit more about Colorado's opioid data for women of reproductive age, so ages 15 to 44 for our opioid data. So this is really showing fatal overdoses, poisoning death rates per 100,000 residents involving prescription opioids and heroin. We're defining the maternal and child health population here as females ages 15 to 44. And rates in the MCH population now are nearly identical to the Colorado rate. So that's, you know, an important thing to kind of take note of. Here we're highlighting the new MMWR, which is something that comes out of the CDC that was released recently, showing the increase in opioid use disorder documented at delivery hospitalization. So when folks go in to deliver their babies, this is kind of what that's showing, an increase in opioid use. The analysis was performed using the ICD-9-CM codes, which is a specific hospital code, and that only goes up to 2014. The codes have changed, and so there's some information that we can't actually compare now that the codes are looking at different information and tracking information differently than before. Prescription opioid morbidity is the next one. We're looking at poisoning-related visits per 100,000 residents associated with prescription opioids. This is from 2011 to 2017. And like I was mentioning, due to the change in hospital coding, we're unable to compare the trends between the two coding eras. So we specifically put this break in the table to kind of show that transition. The rates we're calculating using preliminary definitions for the ICD-10-CM coding, which is the newer code. ED rates have not undergone as much testing as hospitalization rates and are more preliminary. So the information may not be exact at this time as they're still kind of defining that code. However, from 2016 to 2017, we saw an increase in prescription opioid poisoning-related visits, both in the maternal and child health population, as well as Colorado as a whole. And that tracks with national trends. However, hospitalizations have remained fairly stable. Heroin morbidity. So for both hospitalizations and ED visits in 2017, there were higher rates of heroin poisoning related visits in the maternal and child health population. So that's the women of reproductive age, 15 to 44. And that's compared to about a 1.3 time increased rates for ED visits and a 1.2 increased rate for hospitalization. So really what we're seeing is probably we should highlight that there are some treatment needs for this population that at this moment we're not, there aren't very many services to do that. 18% of all controlled substance prescriptions dispensed in Colorado were dispensed to women of reproductive age, and 50% of all controlled substance prescriptions dispensed to women of reproductive age were opioids. That's pretty huge. So women of reproductive age make up actually 21% of Colorado's population. We also see some interesting sort of percentages with other substances and how they relate to Colorado. So 23% of these controlled substance prescriptions went to women of reproductive age, 18% of stimulants is what we're seeing. And so those are things to kind of consider as well. This is what the high dose prescribing tells us. So CDC prescribing guidelines recommend opioid dosages should not be increased to greater than 90 mg morphine equivalents. They consider this like a measurement, the MME per day. So this is what's showing the percentage of high dose, so over that 90 MME per day, opioid prescriptions received in 2017, and it shows women of reproductive age compared to Colorado. Lastly, just going to show you this age-adjusted rate of poisoning deaths by an opioid analgesic. It's basically anything that has opioids in it, any kind of substance with opioids in it. It could be like fentanyl, it could be carfentanil, it could be something that has those qualities of an opioid in its makeup. And this is among Colorado residents by county. And then what you will also see here is a one-pager that we have for prescription drug use among pregnant and postpartum women of reproductive age. This is a handout that should be available online to those of you that are joining us virtually. This includes information about prescription drugs dispensed to women of reproductive age. And then this one specifically we just pulled for Adams County, but this is broadly to Colorado. So the ones that I posted online are just for Colorado generally. It also shows prescription drug use and maternal mortality in Colorado, neonatal abstinence syndrome, and recommendations on what are some steps that we are taking or that other folks that are working on this issue can do to learn more and do more. Next, I'm going to touch on some Pdmp enhancements. So earlier I mentioned that the Pdmp is the Prescription Drug Monitoring Program, and the Pdmp is a controlled substances database. Colorado pharmacies, doctors, anyone who is a prescriber can access the Pdmp. This sits within the Department of Regulatory Agencies, also known as DORA. There are state mandates and regulations that are requiring providers to utilize this substance database. It's also a clinical tool. We utilize it for public health surveillance. It's essentially every time a controlled substance is dispensed, from a pharmacy. The pharmacy is required to upload this information within 24 hours. We cannot track compliance. That's the downfall. However, for doctors, this is a way to really look at maybe if their patients have other prescriptions, so they can make the best clinical decisions for their patients around medication. Some of the projects that we're working on with the Pdmp is to enhance the system, to make it more usable, making the system work better, having different kinds of specialty of providers, and having updated agreements with DORA. In terms of connectivity, we are working to basically integrate the Pdmp with health information exchange or electronic health records, so that when a doctor pulls up the health record of the patient, they can also pull up the Pdmp at the same time, so they can see what other medications they're on, what kinds of health issues may be in their history to inform their decision making. So trying to make it like a easier 2-step type of process instead of 10 steps is really the goal. As we know, providers don't have a ton of time with each patient in the room. And then in terms of surveillance, we utilize the data for mapping, data linkage projects, and especially for MCH support. And I'm going to talk about that in just a minute in one of the ways that we're linking the data for that. Just to give you a really brief overview, these are some of the ways that the Pdmp is being integrated and some of the benefits and challenges. This would be used in a women's health clinic just as much as it would be used in a dental office. And so really having the platform available to providers to just open up directly and not have integrated with another system. The challenge is like it makes the workflow harder. It's not as easy, you can't customize it. But if it's integrated with an EHR or an electronic health record, it basically helps the workflow and you can customize for your patients. There are some challenges, there are some extra costs, there may be some limited access. The health integration exchange options also have some challenges, but those also integrate better into a workflow or a customization. There's also an app called OpiSafe. This essentially is a tool that providers who maybe work in multiple clinics can take with them. If not every clinic has some sort of integration, they can customize it. There are some extra clinical features they can use. There are some extra costs with that, and this is not connected directly to like a health record, so the workflow may be here's some extra steps and here's some extra steps. It takes a little bit longer. The prescription drug monitoring program data, like I mentioned, is housed at the Department of Regulatory Agencies. All medications that are controlled substances, DEA schedules 2 through 4, 5, are recorded in there. We have data now from 2014 to 2018, and each record represents a prescription and includes information on the drug dispensed, the patient, the pharmacy, the prescriber. And then we are able to kind of give providers like a report, so to speak, almost a report card of what their practices have looked like overall. And connecting the Pdmp to the maternal and child health substance misuse priority in particular is a really interesting data linkage project that we really just got off the ground. So for folks who are not sure, MMRIA is pronounced Maria, and this is actually a tool used by the Maternal Mortality Review Committee. There has never been a standardized data system available to support the essential functions of this review committee. However, Maria reflects lessons learned from implementing a previous version of this type of data system. And I think that came from about 13 states that had maternal mortality review committees. Essentially, Maria was designed to support standardization. So for data abstraction, case narrative development, documentation of committee decisions, and routine analysis. We are using the Pdmp to support our Maternal Mortality Review Committee by linking the data in Maria and the Pdmp. The purpose is really to improve the comprehensiveness of the records presented to the review committee. So when there is a maternal death within X amount of time after giving birth or during pregnancy, those are typically the cases that we review. And this tells us, especially for overdose information, if it seems like maybe a suicide or just any case that may be presented, this gives us more information about if they've been on prescription opioids or prescription medication. Some of that information included here, like what drugs were dispensed, how many prescribers, how many pharmacies, just some patient information that is de-identified so that we can make the best prevention recommendations and be able to understand the case a little bit better. So the process looks like this. The Maternal Mortality Review Committee really provides a list of patient first and last name. Then our epidemiologist works with Dora and uses Pdmp reports. They pull for all the patients who have filled a prescription. Reports are partially de-identified, like I mentioned, and they get sent to the abstractor who works on the Maternal Mortality Review Committee. And then the abstractor takes that information and really they decide to summarize which data points they think are the most important to share for the purpose of reviewing the case. And then the patient, they de-identify also the patient information prior to sharing it with the full review committee. We don't want to necessarily give all that information out. This is sort of what that sample patient report looks like. I brought one in the room too to pass around. And so as we're going through a review, being able to see if someone died of a drug overdose, we could look here at which drugs that they were prescribed, how many prescriptions they've had total, what the quantity was of those prescriptions, how many pharmacies they went to, how many prescribers they've had. And we can also tell, because the MME is really important of what folks are being prescribed, we can see what the daily dose for MMEs are as well. And then that information is likely useful in terms of the review. Typically, it's broken out between general opioids and then buprenorphine. So when someone is pregnant and using and wants to get on medication-assisted treatment, which is the best choice scenario for mom and baby, typically they may go on buprenorphine or Suboxone. If they had this prescription outside of being pregnant, that may still show up if it was in the last 2 years or something. And I think we may have the capacity to determine what the date range is, so we can kind of control if it was within the last 2 years or something like that for the purpose of this review. This is not the most up-to-date slide. However, we do know that this is still very much the case in Colorado. For our maternal mortality review, drug overdose was one of the leading causes of maternal deaths from 2004 to 2012. Like I said, that trend still very much seems accurate from the work that we've been doing. Opioids were the most commonly detected class of drugs, identified in 42% of women. And in a majority of the pharmaceutical opioid overdoses, there was documentation of a recent prescription for opioids, a known opioid use disorder, or empty pill bottles at the scene. So having that Pdmp information is actually extremely useful for circumstances like this that we may review. Any questions before I go? I know it's a lot of information I'm sharing. Okay, great. So next we're gonna briefly discuss some of the community strategies that we do for opioid overdose prevention, which are provider education and coalition building. These are the CDC guidelines for prescription opioids for chronic pain. Moms can experience chronic pain folks that are pregnant can experience chronic pain. Those are not necessarily separate things. Folks can have numerous things going on in their life at the same time. So this is, although this patient care guide around prescriptions for opioids for chronic pain is not specific to the maternal and child health population. These are the general CDC guidelines for basically best prescribing practices. And this is one of the biggest things that we do provider education wise. We have 14 community grantees for our opioid overdose prevention program across the state. Some of them are specific counties and local public health agencies. Some of them are non-government organizations, and some of them are area health education centers. All of these folks may be serving their one county or a few counties or an entire region. And this provider education work can be really broad, so folks can help the providers in their area get trained in medication-assisted treatment. That includes talking about sort of the myths and the facts about MAT for pregnant and postpartum women. And I think that that is really a hot topic for a lot of folks right now, and understanding all the nuances that may be important there. The provider education can be alternative to opioid treatment, generally sort of the 101 of what you may need to know as a provider who prescribes opioids. The conversation can be more focused on chronic pain. There are a lot of directions that the provider education work can go, but it was rooted initially in talking about those CDC best prescribing practices and trying to capture evaluation-wise if folks are utilizing the Pdmp. Oh, sure, sorry. So the stars on here, the light blue stars actually represent where we have provided some maternal and child health technical assistance. So we also have counties that have selected this maternal and child health priority. And some of them are considered small communities because they are much smaller health departments, and they have less staff capacity and receive different levels of funding for the activities that they can do. So typically in some of these communities, so that's the light blue stars, is where we have some of that. And I think this map may not be the most up to date. However, some of those communities are like Hinsdale or Mineral or Lincoln, and we know that some of those health departments are pretty small. But Tri-County is also one of the grantees, for lack of another word, working on this priority area in MCH. And I'm actually going to give an example of some of the work that they've been doing to work on this in their community. But the other stars are just showing where there's overlap in opioid grantee communities and our MCH communities. So the blue is really showing technical assistance. The pink is really showing the overlapping communities. So you can see the opioid communities are in colors. So there's like the blue, the green, the yellow, right? Those are like regions or specific counties. And then the pink is really showing which counties have overlap. And that's what's not the most up to date. And then we also provide technical assistance to the Communities That Care project across Colorado. They may also select to be working on opioid or marijuana related activities and do provider education. And so we want to make sure that we're including this MCH population in that education that they may be doing. So like I mentioned, Tri-County Health Department is one of our departments that is really doing an incredible job on the work that they're doing. They put together an issue brief. It was their Women of Reproductive Age Substance Abuse issue brief. And really, I'm gonna pull this up here. Is that this one? This one. This is what it looks like here. And this is available online, but you can also email me if you're having a challenge like accessing it, or would like to have more information. I can connect you with the person who put this together. Her name is Emma Goforth. She really does some amazing work. But here you'll see that she broke things out by substance misuse among women of reproductive age. And then this has information about marijuana, data, tobacco, alcohol, and then prescription opioids. And then you'll also see, there's a lot of stuff around prescription opioids. What you'll also see here is then she kind of switches over to the second part of the report where it really talks about substance use during pregnancy and looking at the same substances. So alcohol again, she pulls data from PRAMS, from BRFSS, from Colorado Health Association, I believe, and she's also done, like they did their own local analysis around alcohol and tobacco use during pregnancy and did some heat mapping, which we thought was super innovative and unique. So definitely very interesting for the Tri-County area. This is something that if other folks wanted to do that with their county, they would be able to have access to some of the same data sources, like PRAMS and BRFSS. And definitely we would encourage any kind of local analysis that may be useful or interesting. I think that some of the things that I thought were the most interesting were really about opioids and prescription opioids. We know that when like a mom gives birth, sometimes she leaves the hospital with an opioid prescription because of pain. And so this is used during pregnancy primarily and for women of reproductive age, so not completely getting at that postpartum piece, but she does talk about maternal mortality, substance use and prenatal care, so she's really included a lot in here. And there is a little chart here as well around neonatal abstinence syndrome, which I will get into shortly as well. So just wanted to highlight, this is some of the way that locals are participating and really doing this work, data analysis and collection, sharing this out. She's heavily involved in the Substance Exposed Newborn Committee work groups and has had some opportunities to really go and show this issue brief and kind of talk through each of these substances and what they're finding in the Tri-County area. And so, yeah, that's really awesome. And then some of our folks in the smaller communities are attending some of those meetings for the Substance Exposed Newborn Committee digitally, just because everyone's so spread out across the state. And so trying to get more integrated in some of what the state work looks like, which I'll talk about that as well in a little bit. So if folks have questions about this or want to be connected with Emma who put this together, or would maybe be interested in a local presentation to understand maybe how Emma put this together and really what she was looking at, I can definitely connect you with her. Just jumping back here. Okay. Now I'm going to talk about some of the partnerships and resources that exist. First, I'll start with the Substance Exposed Newborns Committee. So that committee sits at Illuminate Colorado, and they feed into the larger Substance Abuse and Trends Task Force under the governor's office. This steering committee really envisions a Colorado where a decreasing number of women, children, and families are impacted by substance use during pregnancy, and where those who are affected are identified and supported with the appropriate resources, practices, and policies in their communities and across the lifespan. So they've got quite a hefty vision. We're definitely backing that up. They have a number of work groups. One is a hospital collaborative, which I'll talk about as well. One is a data and research work group. They have an FASD identification work group. They have a plans of safe care work group, a policy work group, and then a provider education work group as well. Their focus with some of these work groups really go through 2020. So they'll convene, support, and guide these work groups to either expand some kind of work or develop or implement a new tool. Every work group is doing something a little bit differently, but these were the priorities that were identified at least until 2020. where they'll have a chance to kind of refigure that. Like I mentioned, one of the work groups is a hospital collaborative, and they are working to increase consistency in implementation of best practice approaches in the identification of and response to newborns prenatally exposed to substances and their caregivers at the time of birth across Colorado. This is through education and formal quality improvement efforts. And so this really, the funding for this work came out of the Children's Justice Act through the Department of Human Services. They partner significantly with Kemp's Children's Center, Echo Colorado, Illuminate Colorado that provides other programming as well. And essentially these hospitals come together. I've, members from the hospital that are working on this to talk about the different policies, kind of share some lessons learned about what they're trying to implement. I want to say they have a group of maybe 14 hospitals right now that are in the implementation stage across Colorado. These are all birthing, like delivery hospitals. And so we'll kind of see what comes out of that with the lessons they learn in their implementation. We also support the Substance Exposed Steering Committee and specifically their provider education work group that is building out sort of a toolkit project. They're at an inventory stage right now. And what we know about that is there essentially is a lot of existing resources with the primary audience being providers. So this group essentially is creating an inventory of existing resources, developed provider-friendly categories. They're vetting it and prioritizing the most useful resources for perinatal providers, and this is kind of going through a collaborative review process. The work group that is putting this together is comprised of prenatal, neonatal, pediatric, antenatal, and addiction medicine providers in both inpatient and outpatient settings, as well as professionals who serve families via public health, behavioral health type of programs. The work group is actually led by a physician who is dual certified in family medicine and addiction medicine, as well as is a neonatal nurse practitioner. So she kind of sits in all those spaces and brings a lot of education and knowledge to the group. The preliminary inventory of existing resources is pretty much complete and contains over 200 unique resources. This is specific to substance misuse and the pregnant, postpartum, prenatal, like NAS, all those categories encompassed. This is for multiple substances, so they're like SBIRT, which is a screening brief intervention referral tool. There is updated policies for hospitals. The categories of resources include statutes, information about substance use disorders, hospital practice and discharge plans, harm reduction, information about breastfeeding and lactation, screening and testing, etc. And so this will be a really comprehensive toolkit when it is finalized. Once this comes together, what we're anticipating is that this will become sort of a digital toolkit. It will live on a website where providers will be able to get on and search in the little search bar to pull up what they need at the time. So we're hoping that the categories that we've divided things into, like clinical guidance and recommendations, or data, or neonatal health resources, will give them a starting point. But then our ideal would be to create like a search system so that the inventory can be searched by keywords, or the year published, or the topic, or the type of resource, intended audience, other kind of ways to search within that. So I did want to show, and this is not finalized, and so we're not actually sharing all this information completely out for everyone to access yet. But just so folks can see, right here, here's one of those one of those categories. This is clinical guidance and recommendations, how language choice can reduce stigma, reducing stigma. A lot of these are, here's something about expert trainings and more about expert, guidelines for identification and management of substance use and substance use disorders in pregnancy, motivational interviewing tool. If we jump down here, you can see this section is maternal health resources. So substance abuse and reporting in pregnancy, opioid use disorder in pregnancy. This one here is about medication-assisted treatment, so methadone and buprenorphine during pregnancy. And so the goal with this is to really highlight what we have that exists that are useful information for providers, and also that anyone can really access this if people have questions or want to know a new tool, you know, are curious about medication-assisted treatment, but they're pregnant and they don't know who to ask. This could be easily searchable online once it's live. But like I mentioned before, the primary audience is providers. So, yes, there's a question. Yes.
So they're counted in your stat
Um,
about drugs.
likely no.
Can you repeat all of them?
Sure. The question was, in the stats, in this one pager that we have, which I'm going to show so folks know what we're talking about. In the stats on this page, where it says prescription drug use or prescription drugs dispensed to women of reproductive age, we are not anticipating that that includes medication-assisted treatment drugs. Those are measured differently, and we don't actually have that data as far as I'm aware of for things like methadone, buprenorphine, Suboxone, things like that. So, gonna jump back here to our presentation now. Whoops. Oh, here we go. If folks have questions or would like to get involved in some way with building out this inventory or with any of the substance-exposed newborns work groups, please feel free to reach out to me. I can connect you with the folks that are doing that work. They're all really awesome and wonderful and dedicated. And then now I kind of want to move on and talk a little bit about neonatal abstinence syndrome. So here are the number of NAS cases, increased 81% from 2010 to 2017. That is a pretty huge increase. As you can see, 2016 seems to be our highest number, and you can really see the number of cases there in the blue on the chart. There's some limitations with this data. The data is based on hospital discharge coding using that ICD-9. What we talked about earlier is that now the codes have changed, so they will not, we won't be able to compare the codes previously to now with the ICD-10-CM. It is not possible to determine from these codes what caused the NAS, and therefore the cases reported here were likely caused by a variety of different drugs. So we actually are not able to report the type of substance because it's not looked at that granular level. Maybe in the next iteration beyond the ICD-10-CM coding, maybe there will be an option. Some interesting things that folks may want to know is that this information is collected by the Vital Records or Birth Defects Registry. So for NAS, this is reportable if you've been born in and live in Colorado. And so if someone came to Colorado to give birth, but then went back to wherever they live, that's not included in our numbers here. The other thing that is really interesting to know is that these cases are not confirmed. So unlike things like FAS that have confirmed cases, right now we don't have any confirmation of cases for NAS. So there is no follow-up referral process that happens with those cases at this time. Also, please note that someone's, you know, if I were to have a baby and I was on medication-assisted treatment, it is likely that my baby will still be born with neonatal abstinence syndrome or exposed to substances, even though mom is doing what she can to make things better and be on treatment. So, you know, for a mom who has given birth and is on medication-assisted treatment, there are some interesting dynamics coming up with some bills that are happening around child code and mandated reporting requirements, because should you know, child services get involved in that scenario? If mom is trying to do the right thing, does it look like the requirements are different? And so there's some interesting conversations happening right now, and there is a bill, from my understanding, working its way through legislation. I'm not sure if it's been introduced fully yet or not, but that is something that's being talked about in this round for folks that may be interested in that. And I guess we'll know sort of what the outcome is if that changes. If not, generally, mandated reporting requires you to report if a mom is using substances and if baby is born in some way substance exposed. Something else that's really interesting about NAS, working in public health, we really look at social determinants of health, so things like homelessness, food insecurity. Some of those are big ones that show up in the population of folks that are using substances. And there are some interesting studies and research being done that are a little bit emerging, but one of the takeaways that we've actually come across so far is that if a mom is food insecure during her pregnancy and while using substances, the baby is likely to be born with a more severe case of NAS. And so we're still trying to see what else comes out with that research, but it may mean that communities would be able to start working on food insecurity or food security efforts to start addressing some of the issues around NAS, which is a really upstream kind of idea to think about how we can approach working on this issue. So when more information comes, I'm happy to share that with folks that are interested. Next, we're gonna kind of talk about the Colorado Consortium. They're another partner and resource for the opioid work and prescription drug abuse prevention broadly. This is a group that was created by Governor Hickenlooper in the fall of 2013. It was to establish a coordinated statewide response to this public health issue, the opioid crisis. The consortium kind of serves as a backbone. They link many agencies and organizations and have a number of work groups that are doing various projects and on various aspects of this opioid crisis here. You'll notice that there's a provider education work group, there's a treatment work group, affected families and friends work group. All of these different work groups, or at least many of them, are also starting to be more intentional about how to consider pregnant and postpartum women in some of the work that they're doing. So when we talked about some of the provider ed work, I know that their provider education work group is really trying to build out a presentation that's more specific to pregnant and postpartum women or women of reproductive age, to kind of address those specific questions and needs that providers may have around this topic. We know that access to treatment is challenging. If you're pregnant, there are less resources, and so the treatment work may move towards a focus on that. We know that the Office of Behavioral Health is really working on this as well, and so they're another one of our partners that is really focused more on the treatment side of this issue. And then, as we know, affected families and friends work group, likely there are folks in there who may be grandparents who are raising their grandchildren because mom passed away, and the impacts of substance use on the kiddos, right? When a parent is a substance user, there are impacts that kind of go through the generations, and we know that grandparents don't always have the strongest support or the family that may take on those children. And so that's another way from the prevention lens, we try to think about resources and ways to kind of address the children's needs as well. The provider education work group, like I mentioned, this is a little bit of an out-of-date slide, but really initially the focus was on safe opioid prescribing and monitoring. And like I said, they've really tried to move towards additional topics. Now they are working to include more information or have an entire presentation for pregnant and postpartum women or specific questions around that. I know they cover it in their medication-assisted treatment presentation that they do. And lastly, I just wanted to list out some additional state partners that are doing various pieces of this work, especially around opioids in Colorado, that we can connect broadly to our maternal and child health substance misuse priority. So there has been an expansion of safe disposal permanent drop box locations around Colorado. There are now naloxone standing orders for public health agencies, harm reduction agencies, pharmacies, etc. And trainings are happening across the state regularly. If that's something that you'd be interested in, please reach out and I will connect you to folks that are doing that kind of training. The important thing to know is that anyone can be trained. And so if you are personally affected by this issue and you'd like to personally be trained because you have a family member that's struggling, we can also connect you to someone who can train you individually. We have our Prevention for Community grants that I mentioned. We have our prescription drug monitoring program that we talked about. We work with disease control partners and syringe access programs. We have some upstream prevention projects coming out of our branch, like Communities That Care. That's more geared towards youth substance use prevention. Obviously, partner with our marijuana folks, and then our maternal and child health overlaps between these topics. Folks not at CDPHE specifically are folks at the Department of Human Services and the Office of Behavioral Health. Like I mentioned, they really are expanding medication-assisted treatment and other treatment. They are also working on helping to fund law enforcement assisted diversion programs to help when folks get picked up for some kind of maybe petty crime, that they can try to get them into treatment instead of jail. They're expanding their crisis services and naloxone, which is also called Narcan. Rise Above Colorado is doing a lot of prevention work targeted specifically towards youth. It's not opioid specific, but it's really covering a multitude of substances. And so they also are someone that we partner with quite frequently. And then we're also always open to partnering with new partners. So if you are involved in this work and anything related to substance misuse, specifically maternal and child health population or not, feel free to reach out to me. Let's have a conversation about it. We're always looking for projects and ways to partner more with folks around the state. And with that, that's what I have for folks today. This is my information if anyone would like to email or call me. For folks in the room, I left my business card up with the other materials. And I'm happy to take questions if anyone has questions at this time. Either way.
Does your division have any updates or an official opinion about safe injection sites in Colorado in the future?
We do not have an official statement about that at this time. Are there folks online with any questions?
I don't see any questions yet.
Okay. And it's also totally fine if folks want to kind of stew. I know that there was a ton of information shared today. You can always email me with a follow-up question, just because I know I just put a lot of information out into the world. So, sure.
How is NAS diagnosed in the hospital and when? And if a mom is on a prescription opioid for chronic pain, will that result in NAS? Could it?
So if a pregnant woman is taking any opioid, that could absolutely end up with baby being having neonatal abstinence syndrome. The severity may look different. It's not best practice to necessarily be on an opioid medication when pregnant, is my understanding, but also that every circumstance is different. And so that's a, I'm not a doctor, I don't claim to be, that's definitely a doctor-patient conversation. But with NAS, I think every hospital has different policies and practices about when they make a call or a determination around an NAS diagnosis. And so that really varies. But out of the hospital collaborative work, there may be more of like a set, this is what we think should be done. This is how much time we think it should take to determine. Severe cases, from my understanding, are noticeable pretty immediately. Less severe or non-severe cases may not be noticeable for some time. And so, that definitely varies.
Online, we have a question. When is the substance exposed newborn toolkit expected to be available?
We're in the process of determining that now. So our unit funded the initial development of the inventory list. We are going to be in our next round of, we're applying for more funding from the CDC. Our current funding runs out from them at the end of August of this year. And so with the hopes that we apply and are eligible and get funded, there may be an opportunity to expand and get this toolkit up and running online. At this time, we don't have specific information about that, but we are hoping that within the next year there will be some kind of funding available to move that. And I know the Substance Exposed Newborn Committee is definitely dedicated to that. So although we don't have an exact time right now, we definitely hope it will be in the next year. Okay. Well, please feel free to email me. Like I said, I often work off site, so although my office number is on there, I'm definitely best reached by email. And so feel free to send me any questions or comments you have, or if you want to get more involved in a program or something else that I talked about today.
Oh, sorry, one more question.
Sure.
What do we know about the long-term impact of neonatal abstinence syndrome?
Not very much. There's research that really needs to be done. Not that this hasn't been an issue long ago, but also hasn't been as much of an issue as it is now. And so there's emerging research and information coming out. And that's something that we hope to learn more about. But similarly with marijuana, there's also not a lot of research out there. So if a baby is exposed to opioids or marijuana, we know a lot more about alcohol, but for other substances, there's still a lot of research to be done, and so we really just don't know very much right now.
Thank you.
Thanks, everyone. Do you want